Good morning, everyone. Welcome. It's just a little early, but we are all fresh and ready to start this very interesting presentation, with a very interesting event for the patient community in the ECCO Congress. So welcome to Berlin. And I'm Salvo Leone. Today we are speaking about the patient preference survey and why this study. The study is important because the IBD treatment landscape is quickly evolving. We have a lot of drugs coming to the market, and understanding how patients perceive and value treatment attribute is the key. We want to know how the patient perceives the new drug, and we want the market to understand that the drug is not anymore a product, but is an experience for the patient. It's not anymore a drug to take in order to have a better condition of the quality of the organ, but the quality of life. So the study is important because we wanted to determine the patient preference for IBD treatments and attributes, and also to explore variation in this preference, because we have to consider at this point that the unmet need of patient are related to different items. The severity of the disease, the phase of the disease, the gender, the phase of life, because youngsters are different than less young, and of course, since we are moving to a multicultural society, we have to take into account the ethnicity and the culture. So we have to thank you first the University of Leuven, who cooperate with EFCCA in analyzing all this data. Of course, EFCCA members for the excellent collaboration. A special appreciation for the people who participated. Today we are going to present a survey that collected 1,500 answers. So it's a very important survey for the quality of the data and for the number of the survey. Let me scroll quickly through the agenda to present the speakers of today. Of course, after my opening remarks, we're going to have Professor Britta Siegmund, ECCO President, that I thank for being always next to us, like they said, with the Scientific Society. Then we're going to have Professor Bram Verstockt of the University of Leuven to set in the scene. Maria Stella De Rocchis will present the journey who took here today. Elise Schoefs will present the result of the patient preference survey, and then we're going to have a panel discussion putting the patient under the spotlights. We're going to have Roberto Saldana, the DIVA patient opinion maker, and Vasiliki Vakusti, a youngster perspective, of course moderated by our CEO, Luisa Betano. I forgot to tell you that during the presentation of Maria Stella, we will ask you to answer a question using Slido, so keep your phone ready to look on the screen to answer this question. Then we're going to have the perspective of the beginners, Cathy Walsh and N-ECCO, and then at the end, as always, question and answers and the closing remarks. So I'll give you the floor, Britta. Thank you for joining us, and have a great meeting.
So thank you, and thank you for the introduction, and a very warm welcome to Berlin. Willkommen in Berlin. Berlin is my hometown, so the view on the city from my perspective is entirely objective. But I love the city, and I hope you realize over the next days why Berlin is a city that you really can love and enjoy. I also really like that we could integrate the EFCCA Forum again into the Congress. I think this is a big plus, and we need to keep this because this shows what ECCO really is about. It's about the patients. And if we don't speak to each other, either us are not successful, and I think it applies to your side as well. So I think doing this jointly is very, very important. And along those lines, ECCO really likes to thank the EFCCA for the EFCCA grant that supports the ECCO school for now over a decade. And I think the role of nurses within IBD care has become more and more prominent over the last decade. And for me, the nurses in our team are equal partners, and without them, we are actually not functioning. So a very big thank you from ECCO to EFCCA. So what do we have as a couple of special things this year at the Congress? First of all, we have the nurse-guided poster session to increase the role of nurses in IBD. This is going to happen tomorrow in the poster session. And then the topic of this year, and we started the REACH strategy last year, and this year our focus is on the A for attain sustainability. It's a little bit difficult, attain sustainability. So we have a gallery in the City Cube on the level 1 on all the efforts we are following for maintaining sustainability. And there will be a lot of topics and meetings around the Congress on this. We have an IBD nurse education program that we had for a while, which is going from country to country. This year, it has been last year, will be this year in France, in French. However, we realized last year, or over the last years, that with this approach, we are very slow. Because we're visiting a country, so we cover a country like every other year, and if we continue like this, the IBD nurse education globally will be very slow. So we needed a new strategy, and that we will introduce this year, and it's the Train the Trainer program. What we're gonna do is we will invite teams from countries around the world, and always a physician and a nurse will come to the course, get all the educational material we have, and can then go back to their respective countries, use our educational material in order to train the nurses around the globe. And we think with this strategy, which is a little bit like an ambassador strategy, we can sooner reach a more global community and can facilitate that nurses around the world are able to take care of IBD patients. The second thing, which I'm personally very proud of because it's, I think, a very good and important step for ECCO, is we are launching a new journal at the end of this year, which is JCC Plus. And Plus implies that we want this to be a global journal, with a broader scope, so including views of nurses, of surveys, of dietitians. So I think we really want to embrace here the entire community. So, and with this we hope that we can actually catch the entire IBD community. And Johan Burisch from Denmark will be the first entry. So I already introduced this, the REACH strategy, which includes 5 clear goals, and we are focusing each year at the Congress on one letter. So last year it was the E, the equity, and this year it's the A for attain sustainability. And what we are actually doing is that we assess the activities within ECCO and look where do we have gaps, what are we already doing to maintain sustainability, and then we fill the gaps with new activities within ECCO. And I think we never have the problem that we don't have enough activities. It's more like how can we merge activities to make them possible, because the community around ECCO luckily is very, very active, and this is very good. Okay, so the R stands for rapid diagnosis and treatment, just to repeat this, and will be the topic of one of the coming years. E we had last year for equitable access to IBD care, and I think we introduced a number of measures to do this around the globe, and I think one is the Train the Trainer N-ECCO course. A will be this year. C course will be in one of the coming years. And the holistic IBD care, which we believe is a very important letter, will be the topic of the Congress next year in Stockholm. So we can only do this together. So let's reach together, and I wish you a very good Congress here in Berlin, very good discussions this morning. And excuse me if I have to leave soon, because I need to make the next welcome and the next session in another meeting. But I'm sure you will have a very productive morning, and happy to see you around the Congress. Thank you.
Right, so good morning everyone. I'm Bram Verstockt. I'm one of the gastroenterologists working in the University Hospitals of Leuven, Belgium. And it's really a pleasure being here today in such an important forum. So thanks to EFCCA, not only for leading this, but also for the partnership with ECCO, also with our institution. And I truly believe that this is absolutely, as Britta already said, the way forward, where we really need to partner across all the different stakeholders. So I was asked this morning to give a perspective from the clinical side, like what do we as physicians appreciate in our discussions with patients when it comes to treatment decisions. And you will hear way more afterwards from Elise and the work she's been doing. So I will just provide you with kind of an introduction, and then Elise will introduce the results of the survey we did together with all of you. So let me start just by giving you an example of someone who was recently diagnosed with inflammatory bowel disease, and this is obviously a story which will sound very familiar. Someone at an early stage of their life being diagnosed with a lot of debilitating symptoms, the bloody diarrhea, the stools, frequency also during the night, so a lot of important aspects impacting their quality of life. And then obviously patients reach out to us for help, and we obviously would love to help, and then comes the discussion on what should we do, what is the best strategy to help that individual patient. And we were very grateful 20-30 years ago when the first advanced therapies came onto the market, that we did no longer had to focus exclusively on steroids, but we had the first biologicals introduced back end of the 90s and beginning of the '90s, and ever since there have been many more. And this is just a snapshot of what is currently available for Crohn's. For UC, there are even more treatments currently available. And I think this is wonderful that we have so many treatment options now, but it also brings some challenges on what to do and which drug to pick, and that's exactly why it's so important that there are these discussions between patients and physicians to come to a joint decision. And I deliberately took the case of someone with Crohn's disease in the terminal ileum, because in these people, it's not only about discussing treatments with drugs, it can also be, and there is scientific evidence, that these people might equally benefit from surgery. So that means that from a medical perspective, it's not just a discussion on which drug to pick, but also which strategy to pick. Is the patient, that individual in front of us, is this someone who is really afraid of side effects of drugs? Is this someone who would rather prefer surgery instead of going on immediately advanced therapies? Or the contrary, is this someone who is really afraid of surgery and prefers to have a medical treatment? So these are very important discussions we need to have together to come to the best decision for that individual person. And this is exactly the whole concept of shared decision making. And this is exactly the very strong belief we have in our unit, and the way we try to practice in Leuven is in joint partnership with our patients. It's no longer the physician who is deciding what is actually the only treatment this individual should get, but let's do it together, because this will actually impact positively also adherence to medication. This will also positively impact patient empowerment if we really do this in partnership. So how is this basically, what is this concept of shared decision about? Obviously it all starts with being a team and seeing each other as equal, and not being the physician just deciding on its own, but seeing this as a joint effort between patients and physicians. So the first part here, the number one, is let's do this as a team to make a joint decision. And obviously if we want to do this as a team, then we need to speak. And we as physicians, it's our role to inform you as patients about the various options there are, and what are the pros and the cons of a specific treatment in your individual situation. So we should provide you with all the options available, and then we should come to a joint decision. So all these steps are very important, where obviously it's not just about us talking on what is available, but also about you talking to us and we actively listening on what your concerns are, what your preferences are. And this is where this whole forum is basically about. So how do we try to implement this in daily practice? Because this might sound very theoretical. So one example is that basically those patients in whom we think that surgery might actually be a valid treatment strategy, that's why we established a couple of years ago a multidisciplinary clinic, where every single patient is not seen by me as a gastroenterologist alone or by my colleagues from surgery alone, but we see the patient jointly. So we can really discuss together with you the pros and the cons of a given treatment, being it medically, being it surgically. And you can see that in this clinic we obviously involve all the people who are important in our MBT. It's not just about us as physicians, it's equally important to actively involve our nurses, to actively involve our dietitians. We have a stoma nurse on that clinic if we have to speak about the need for an ostomy. We have our psychologist around if we would feel that there is also a need from that perspective. So the holistic approach Britta already introduced you before is actually what we try to bring to the clinic. Of course, we don't need to discuss surgery with every individual. So in those patients in whom, for us, medical therapy is actually the next option, this is actually the corner of our GI clinic where we have to speak about medical therapies. So this is a leaflet we designed a couple of years ago, which we have in French, in Dutch, and in English, and where basically all the currently approved therapies are on. And again, to have that aspect of information and education, we try in layman terms to discuss with the patients the various options which are currently approved in our Belgian setting. So we briefly and very basically try to explain how the different drugs work, because they all have differences. That's the first thing we always very briefly introduce. Then we explain how the drugs are being administered, being IV, being sub-Q, being orally. We discuss what the impact might be on additional comorbidities, the beneficial effects on skin, on joints, on the vertebral column, and any other extraintestinal manifestation. And then finally, we don't put explicitly all the safety concerns on there, because that obviously, if you would read the SMPCs, that would require a lot of information. So this is something which we explain also verbally. People can make notes. We sometimes make drawings to also actively address that safety aspect. And then obviously there are many more things which we should consider as physicians, and again, where we should guide you. I think it's very important, and I just strongly believe in transparency, where we at least don't hide any information and where we provide all the therapeutic strategies there are. But it could well be that among all of these drugs that there is medically, scientifically, a strong preference for one drug over the other. So we do take as physicians into consideration the specific features of that individual patient in front of us, and we try to explain why, for us explicitly, that drug would be preferred over another. And I'll give you one simple example. If we have a newly diagnosed patient with Crohn's disease who's been suffering from perianal fistula, most of the scientific evidence is still on infliximab. So we will explain and go through this leaflet and describe all the options we have, but we will also strongly state, well, actually what we think would be the best option for that individual is actually the infliximab. But it's very important that people know about the alternatives so that there is a lot of confidence on both sides, so that we are fully transparent and we take all these different aspects into consideration. And of course there are discussions about side effects, there are discussions about speed of onset. We need to consider comorbidities, and Elise will tackle all of this in her study results as well. But what is obviously very important is that we understand as physicians what is extremely valuable and important to you. And that might be different from individual to individual. So it's good that we have now, thanks to the survey Elise did in collaboration with EFCCA, that we have kind of a sense on a global scale, on a European scale, what a large group of patients think, but now we need to translate this to the individual level and really understand for that individual in front of us what is actually very important to that individual. And that's where patient decision aids come in. These are tools which can actually not only inform and increase the knowledge and do patient empowerment, but also kind of decrease what we call, with a difficult term, the decisional conflict. If you as patient have so many options, it's very difficult to make a decision. So we are there as physicians to guide you, to help you to make that decision. And these tools can really help you to give us some insights in what is very important to you. So what Elise and the team of Isabella Heus, in whose lab she's working, is basically doing is developing this online tool in partnership with EFCCA, in partnership with the Belgian Patient Society, where this is an online tool called the IBD Select, where first of all there is provided information. So our leaflet I showed you before is integrated there. And then, based on something I will explain you later, we can identify what the preferences are for that given individual in front of us. We and you as patient, we get a report so that we can actually, in the consultation in which we will discuss the different options, we can actually guide you and really already try to incorporate what really matters to you as an individual person. And this is actually the strongest example of integrating a shared decision model. Saying how can we try to basically understand what is important to you? There are a lot of scenarios where you need to pick one over the other. So I'll give you the example here. Let's say you have treatment A, which is administered via an infusion. There are positive effects on joints and skin and eyes. You have little risk of skin problems. You have some risk of serious infections. And there is actually very low risk of cardiovascular infections. At the other side, you have an oral therapy, treatment B, which does not have all the positive effects on the skin and other things, which has way more risk for skin problems, little risk for serious infections, but more cardiovascular problems. And this could sound very abstract, and it's not specifically targeting a given drug, but it's just by stimulating you to reflect on what matters most. And so there are 16 scenarios in this tool where you always need to pick one, and by the end, if you went through all of these scenarios, we get a report. And we understand what is very important to you. And for instance, this is just one example. This is someone in whom the risk of cancer is the most worrisome. And of course, we all we all are afraid of side effects for sure, but there are subtle differences between patients. For some patients, it's way more important that the drug works quickly, and in others, the safety aspect is way more important. So by going through all these scenarios, we get kind of a sense like what is very important to you as an individual. In this case, the risk of cancer, the risk of severe cardiovascular problems. We need to consider the way the drug is administered. And it can really help us to guide the consultation in providing you the exact information of what we could offer you to help you. And this tool is not developed to say, well, if you complete the questionnaire, this is the drug you will get. No, definitely not. It's not a tool which is designed to promote one drug after the other. It's a tool which is designed to understand better what is actually important to you individually, so we can help you in making the best decision together. So in conclusion, I hope that in the past minutes I've shown you that we strongly believe in shared decision making, and I truly hope that on a global scale we can make this shared decision model really the standard of care for all patients with IBD, to get every single patient with IBD actively involved in their treatment decision, because that's what's very important. The paternalistic way of a doctor deciding what the treatment is you should take, I think, is gone, and it should remain gone. We should do this in partnership. So that also means that physicians, nurses, every stakeholder in the MDT should be trained to have the skills to incorporate this in practice. And sometimes this also requires organizational changes in how we do our clinic. And I think this is definitely the way forward. We get a lot of feedback, and I think the survey Elise did really demonstrated that from a patient perspective, this is very much valued. There is a lot of willingness and strong beliefs in shared decision models. And I truly believe that actually patient societies like EFCCA are really pioneering in this. And this is what we really need if we want to create further awareness about this shared decision model, so that we can further empower patients on a global scale to make this happen, and that these patient decision aids could really help us in making the next step. And with this, I really would like to thank you for your attention. Once more, I would like to congratulate and thank EFCCA for this fantastic symposium, and I would like, obviously, the entire team in Leuven to be thanked, and especially Elise and the whole team of Isabella Huis, who has been doing a lot of the research which will be presented this morning in partnership with EFCCA and with our IBD unit. Thank you very much for your attention. If there are any questions, I'm more than happy to take them. I need to run to a next course to give a talk, but I'm more than happy to stay a few minutes for questions.
Hi, my name is Maria, and thank you very much for the presentation. My question is really, I think this is one, I've been waiting for this. I'm a trained nurse more than 24 years ago. I was practicing as a nurse in NHS, and I think it's, you know, this is really amazing. So my question is really, how are you transferring this tool to other hospitals, or how
Sure.
what's the plan for spreading it?
This is definitely the next step, and Elise might comment on it also in her talk. So the first part was a survey for which we will show you the results today. The tool has now been developed. We are currently piloting this in a proof of concept study to get additional feedback from patients, to see how, now that we are actively using it in the clinic, how it is being perceived, what we can optimize. So it's a beta testing at the moment. So, and once this is completed, obviously this should be expanded, and this can be put online and can be used by many people. So it's definitely not something which we want to use exclusively in our unit. This is something, again, in partnership with EFCCA, which can and should be used around the globe.
Any other question from the audience? Yes.
Hello, Martin Christopher, patient advocate. I was wondering, do you see this tool as like free to use online, or would it be like a subscription license for the hospitals to use?
I hope truly that this will be free for use, and should not be behind a paywall, because otherwise it's a completely missed opportunity. So that's my honest feedback. I think obviously always this all needs to be discussed, but I think if this would be behind a paywall, then it's actually not doing what it should be doing. So no, this should actually something really freely available to all patients and to all patient societies.
Hi, Saad, also a patient. I'm just thinking, if we have to involve a psychologist, a dietitian, what else? It's usually we already have huge queues to get to the doctors. Now having even more doctors, would that kind of, I don't know, make the process much longer, and therefore you kind of lose the momentum of curing?
I'm not sure if it should substantially delay. I think it's more to provide and create opportunities so that it's there in your unit. We are definitely not pushing all of our patients to our dietitians and to psychologists, because indeed that would not be feasible. There are unfortunately too many patients suffering from IBD, but I think at least providing it and communicating to your patients that, you know, if you need it, it's there in the unit. I think this is a first step, and this is exactly what we do. We have like a leaflet from our unit with all the contact details of all the stakeholders in the team. If they have a question for our psychologist, they can send an email and they will get an appointment. If they need dietary advice, they can be seen by our dietitians. And this is the flexible way in which we, I think, should all rethink our IBD units in the future.
Makes sense. Thanks.
Thank you very much. Wishing you a wonderful rest of the Congress.
I have a question as well.
Okay.
Is that okay? My name is Olivera. I'm from Serbia. Actually, I think we've met during one of the
we
events.
are in the same guidelines,
Yeah,
right?
same guidelines, true. I have a question about the dietitians. Are they like specially trained in IBD nutrition, or are they just like regular dietitians? Because I'm sensing there could be a difference.
Yeah, there is definitely a difference, and I think the dietary ECCO, so DECO, is heavily working also on a kind of a curriculum specifically dedicated to IBD. So the first nutritional consensus from ECCO will be published in the coming weeks. So to provide at least a framework and some guidance. And you're completely right, there is clearly a difference with a dietitian who is generally trained and someone who is really dedicated to IBD and who knows all the subtleties and the suffering patients with IBD are going through, and how their dietary advice is different to the general population. That's absolutely correct.
Thank you for that, because in Serbia we really have a problem with that, because we don't have trained dietitians for IBD, and that's something that we are trying to work on, but it's really hard. So yeah. I'm guessing the guideline will definitely help with that. Thank you.
Thank you. Sorry.
Thank you. Adam from Israel. We also have those IBD with psychologists and IBD nurses and everything, but this system looks really like something we all as patients need. And I'm mind-blown by the decision making with the patients. Is it going to be available for all patients worldwide, or just...
Well, the tool for sure, that's our aim, that it's globally available and that it's not exclusively for our unit or for our country, but it's something freely accessible to all.
That's right, thank you.
Okay, so I know you can wait for the results, but before Elise's presentation, I will going to give you some background information about this study and how we arrived to collaborate together. And as Salvo was saying, I would like also to break a bit the ice with you and ask you a question. It's completely anonymous, so everyone is welcome to participate. And the question is, So we are talking about patient preferences. So in your opinion, and I see here also different stakeholders from the audience, what are the benefits of including patient preferences in the decision-making process? So we don't have, there is not any correct or incorrect answer. So you can, you are free to answer whatever you think. We need it now. Oh yes, sorry. And I forgot to tell you, yes, you have to go to slido.com and enter the code 1141830. And once you are there, oh, yeah. Okay, so someone is still typing it. Okay. Yes, I'm going to be back. So why is it important for you to include patient preferences in the whole process, in the whole product life cycle process, in any decision-making process? This is just to break a bit the ice, and I'm going to share with you the answers that we got so far. So we have holistic treatment and understanding, more IBD, better compliance and persistence, patient psychological safety. This is a good point that we also see during the Elise presentation. And reality check, real needs, achieve shared goals, risk mitigation, increase engagement and compliance again, so patient autonomy and empowerment, treatment plan more likely to be followed, better outcomes for patients, better outcomes. Okay, yes, I think I collected all of them. So we'll go back to these questions at the end of my presentation. I will share you what is the EFCCA perspective about this, but I think we are quite aligned, so no problem. And so I will start by saying that we were doing some literature review at EFCCA, and we discovered that unfortunately there were some little scientific evidence around patient preferences in the IBD community, because most of the time preferences from the two different positions, so physicians and IBD patients can different each other, and you have experience with that. So physicians can be maybe focused on having improved therapeutic outcomes, or focus on advanced drug administration or on surgery, and while patients can mostly focus, for example, on improving the quality of life, on minimize fatigue, or reducing abdominal pain. So, and this is something that we should all know about that. We are aware of it. So there was very little scientific evidence about that, and many questions to answer. Many questions to answer. So just to give you an example, which quality of life effects are important to patients, and what characteristics should have the future drugs in the market, and what side effects do patients want to avoid once for all. And to address all of these questions, we started our collaboration with the KU Leuven, and we performed together the patient preference study. And just to give you some timeline references, we made a parallel literature review in 2020-21, and we were searching for more information about patient preferences on IBD, and Elise and the group from KU Leuven was performing a qualitative research in Belgium with Belgian patients. And we met at end of 2021-22, and to define a quantitative survey this time, and to analyze together the methodology, the objective of the study, and what we want to achieve with these results. So in September 2022, we launched the pilot phase, thanks to English native speakers patients, and we translated also in 15 different languages, thanks to the support of our members community. In July 2023, we launched it until August 2024. And in the meantime, I think it's important to remind all of you that we had a poster session last year, same at ECCO in 2024, with the preliminary results. And today we are presenting right now we will be presenting the final results of the survey. With the team of KU Leuven, we got 2 publications, one of the qualitative study on 2022 and another one in 2024 about the protocol of the quantitative study that we performed together. 3 final poster presentations, the one at ECCO last year showing the preliminary results, another 2 at ISPOR Europe in 2022 and in Copenhagen 2023, exploring the methodology of this questionnaire. In terms of development, so starting from the literature review, the team of Leuven was checking the previous patients' preferences studies, all of the available treatment on the market, because this survey, this question it's actually about treatment therapies, and so they checked the clinical trials available, and I also, of course, took into account the qualitative research that I made in Belgium with a group of patients. And so we started collaborating together, and we composed. This is the strength of the study. It was a collaboration together with patients. We created this advisory board discussion. We had 2 patients, 2 EFCCA representatives joining, 4 gastroenterologists focused on IBD, IBD nurse and a statistician. We met regularly during over years to perform the survey, to discuss the survey aims and the methodology, and of course to ensure that the questions were relevant, clear, and reasonable, of course, for patients. And this is really the strength of this study, also as Professor Verstockt was saying about that. And in terms of the aims of the survey, we wanted to identify IBD patients' unmet treatment needs. We wanted to measure the importance of the treatment attributes, and we wanted to examine how patients' characteristics can influence the patient preferences. And the survey is composed about 10 different parts. I will not go through each one, but I think it's important here to highlight that the core of the questionnaire was the discrete choice experiment questions. So something that also the professor shows previously when we were discussing about the tool. And so we defined it together, we ended up with 14 attributes related to IBD patients and treatment disease. In each of these attributes can have a range of 2 to 5 levels. So I'm going to list the 14 different attributes that we discussed together and we defined together, because these are important, are the core of the survey results. So we thought that it was important to define treatment characteristics, to focus on risk of undergoing surgery, the frequency of having to go to the toilet, the urgency and pain of having to go to the toilet, the severity of abdominal pain and cramps, the severity of fatigue, the frequency of sleeping problems, the severity of psychological impact, the risk of serious infection, and the duration of severe physical change, the duration of severe skin problems, the decreased libido, the way of the treatment is administered, and the achievement of long-term endoscopic remission, and lastly, how fast the treatment will work. This for us was the final attributes to focus on. And as you can see here, I put an example on the left on one of the 15 questions that we included in the questionnaire. So basically, we ask the respondents to choose between 2 hypothetical treatments, so the treatment A and the treatment B, according to 4 different attributes listed that I listed before, and each attribute could have a level from 2 to 5. And so this is an example of the 15 questions that we decided, and we got several interesting answers that we'll see after on. And in terms of the piloting, we did it together with our members, Crohn's and Colitis UK, that I want to thank again for the great collaboration that we had. And in terms of translation, we translated, as I said, the survey in other 14 languages, and I want to thank once again all of our members who helped us with the translation, and they cooperated with us to make it possible. And in terms of main information of the study. Something to remark, it was an online web-based survey with a length of 30 minutes. It was available in 15 languages, so it was shared globally in 46 countries around the world. It was addressed to IBD patients aged 18 years old and plus, and then distributed through our national members who support us with the dissemination, and also through the KU Leuven channels. So going back to the initial questions, I made some research on DIVA, which is our the flagship working methodology that aims at identifying patients and address patients' unmet needs. I discovered some answers regarding the questions that I made before. So it's important to include patient preferences in the decision-making process. First of all, to inform regulatory decision, which means that patients' preference data can help regulators to understand which treatments are more suitable for individual patients, influencing benefit-risk assessment and approval decision. And we also released 2 guidebooks for our patients, the one on the clinical trial protocols and the other one of HTA that everyone know about this. And how can we translate this information? So for us as EFCCA and also for patients, this means that the development of treatment and therapies can be better meet patients' need. We can help developing safer and more effective treatments. We can also improve treatment outcomes and quality of life of patients thanks to patient preferences. And of course, we can also address quite early on the risk and side effects of the treatments. Another reason why it's important to include patient preferences is to align with patient values, because patient value therapies based on their perceived efficacy, on their perceived safety profiles, and the impact, of course, on their daily lives. So, including these preferences ensures that the treatment outcomes align with what patients find most important. And this approach ensures that the chosen treatment reflects what, patients take more of that. And in this way, it's important because treatments are more likely to be accepted and adhered to by patients. And also the time, the resources, the money spent on the new treatment are really valuable if we include also the patient's perspective in this. We can much more focus on this and don't waste time and research on useless treatments and therapies. And lastly, we also have the patient-reported outcomes, which are very important, but while they provide information about patient feelings and quality functioning, the preference studies offer insight on the treatment characteristics that I explained before, and you will see this in the results. So it's important to combine them and to have the full picture of the patient's perspectives and thought about that. And these results, we hope that will contribute to have a general picture of the patient preference in Europe and beyond, to have a country data for comparison on how to support patients in the clinical practice, and to assist, of course, our national associations in advocating for their needs. And EFCCA is committed, of course, to offering to our IBD community support on sharing national reports with our national members. So we'll be sharing soon national reports with national data, and we'll provide you with guidance to interpret this data effectively. And we will also assist you in maximizing these findings and support you to make some impactful decision. I forgot to mention that we are currently submitting the final manuscript with the final results, so until the manuscript will not be submitted, we cannot disclose any information, so you will be receiving the national reports after the submission of the paper. And I want to thank once again all of the patients who took part of the survey, and all of the national IBD National Association and the EFCCA IBD National Associations for their invaluable support in this study. Thank you very much.
Hello everyone, I'm Elise Schoefs. I think the majority of you knows me. It's my pleasure to be now the moderator of discussion that will involve two of our patient representatives. So I'm delighted to call Vaso from Greece. She's the president of the She's the president of the Greek Association, and she's also the coordinator of the youth group. And Roberto Saldagna from Spain. He is our EFCCA coordinator for innovation and patient engagement. Welcome. So we don't have that much time, and I think that the discussion was really rich, and we got a lot of food for thought. And I think that before starting chasing you, what is important for you all to know is that this is just the starting point. We have the chance to start the analysis in depth. We have the final outcomes. As Maria Stella and Elise already said, we are waiting for the publication of the article, of the manuscript, and then after that we will work more by cross-checking information, analyzing them, and try to identify not only for the first top 5 countries in which way, as Maria Stella was saying in her presentation, we can support our members, but in general the IBD community, to interpret the data and also to use them for advocacy, empowerment, etc., and even training. So it's just the starting point. And I hope that in the next months we will have more information and possibly being able to disseminate more the outcomes. So, now it's your time. I just wanted a quick question just to start the engine. As I was saying, we heard a lot of information and a lot of outcomes. Just a quick reaction about your thoughts about the presentations in general and the results that have been presented now, and then I will go in depth with some more precise questions on some topics, okay? You have this microphone?
Okay. Good morning everyone, and thank you for being here today with us. My first comments for the presentation and the survey is that it is a very useful survey with results that we can use to make real world and evidence-based patient advocacy in order to have better outcomes, better choices, and better quality of life for patients with IBD. And so I think that the future will be better and brighter. And we can, if we use the data from this survey correct, we can make a lot of things as a patient advocacy groups and patient community. So I think it's important that it would be great that the EFCCA, in cooperation with Leuven and all the national associations, run this survey. It's really, really important to have this data.
Okay, we have a lot of information to digest. So this is a starting point, but also an open debate, because some of the result has been completely unexpected, other makes sense. The interpretation of the result is going to be a challenge, because there is a lot of to keep talking. Skin issues, for example, it was completely unexpected. We knew that there were issues with the skin, other skin-related conditions, comorbidities, symptoms, but it was unexpected, this priority in our preferences. So we need to keep it talking, and this is the start.
Okay, thanks. And now I would start by asking you something that is not really what we heard as priorities, but it came out from some of your comments or questions from the floor. And I would like to start from the issue of risk of surgery. We saw Italy is one of the most concerned countries among the priorities, but I'm wondering, we know that talking to our people is a significant concern. So, but as I was mentioning, it's not in the 3 top priorities. Can you comment a bit on this?
Yes, maybe this result makes sense. because it's influenced by the condition. It's not the same Crohn and colitis. It's not the same the time, the same diagnosis. And we said at the beginning of the event that the treatment landscape is evolving, but as well as we are doing it over time, because we are not the same people. We are aging. Yes, we are aging, and we are learning from our own experiences with the disease, the symptoms we have been experiencing, the expectation we had with the treatment. So at the beginning, for example, it's very common to live in fear of the possibility of going through the surgery. Then after time, with the condition, with the treatment, everything changes. Even with experiences, with the surgeries. People, and we knew that ostomies, we are scared about ostomies. However, when you have been in that scenario, with time, people get their life back, their quality of life. So, and we have been learning also from them. The one who have not been going through the ostomy, we have been learning from them, and now we are accepting more the surgery as an optional treatment. So we are contextualizing better the good things that also are surgery offering to us.
Surgery is undoubtedly a major concern for many patients with IBD, but the survey indicates that people give a precedence to day-to-day management of the disease. This has many reasons, but one reason that I can think also is that they prioritize things that impact directly their quality of life and their daily life. And the other one is that with the advancements in therapies and innovative treatments, maybe surgery is not such an immediate threat for many patients. So this makes symptom control and daily management of the disease more pressing concerns for patients. And this is another option at the indicators and the factors that are prioritized by patients. And maybe this is an answer to why it's not on the top 3 priorities of the survey.
Thank you, Vaso. And keep the microphone, because I would like to focus a bit more on the above 30 IBD patients. As Elisa was saying, when you look at the younger patients, we see they give greater importance to all the attributes compared to the above 40 or 45 years old patients. So all the attributes are taken highly into consideration from the younger population, not just the 3 that we saw were the most important one, plus fatigue, etc. So what are the key insights that you can draw from this data, and on the basis of the discussion that I know you had in the youth group while trying to define some of your perspectives and the insights you got? Thank you.
Yes, the findings reinforce what we often hear from young patients with IBD. Young patients tend to have higher burden of the disease and a higher psychological burden, so it's likely to impact their education, their social life, their work, so they have a bigger burden of the disease in comparison with older patients. Also, fatigue is a major concern for young patients because it affects their daily lives and their ability to work, to study, to travel, to have a social life. And the fact that younger patients prioritize all attributes more also reflect that there is ongoing process and struggle to gain control of their disease and their day-to-day management of the disease in order to maintain a sense of normality in their lives. And we have to focus on this because many IBD patients are young patients, and we have to focus in order to find better solution for this this age group, let's say.
Then do you want to comment on a bit on what Vaso is saying?
Yeah, and also I was thinking about how pediatric patients, when they started with with the condition, they have more active symptoms, more severe symptoms. So if they have been evolving also with this severe condition, even when they are younger and not pediatric patient, they need to control their attributes better or in a different way than other patients who have been diagnosed later.
Yes. I was thinking, because we have been talking a bit about fatigue, I know that many of you are thinking that fatigue is a very, very important factor in the daily life of any patient, no matter if they are young or old. I have to say that combined to fatigue, what was interesting to me, and I would like to understand your viewpoint, is the aspect of the psychological impact. Vaso was already mentioning it related to the young age, because we can easily understand how difficult can be managing a disease when you are young, you are seeking for a job, you would like to have a normal social life or a relationship, etc. And so it's clear that for young people, young patients is super important. But since we have a tool that is our DIVA tool, I would like to know from you and ask if you had the chance to check a bit what is available in terms of literature through DIVA, and if you can share some of the thoughts, let's say, because DIVA is thinking, that DIVA shared, and it would be nice to hear from you about the psychological impact and the importance of this attribute, generally speaking, in the IBD patients community.
Yeah, well, one of the most important things about DIVA is how it's helping to consult the literature on PubMed and also the patient perspectives and how DIVA gives answer according to what is published, but with the context of the patient perspectives. Because it's not the same to say, for example, that we are experiencing fatigue or pain, that saying that we are suffering pain when we are driving to our jobs, we are performing our daily task. That context is what's really important to understand the real impact of the condition in our life. And this is what DIVA is providing to us, the testimonies, the explanation of the symptoms and the real impact of the condition. There are a lot of examples, and now one of the new features of DIVA is the capacity of the system to integrate the testimonial in every explanation to contextualize the information for us and for other stakeholders too. Because we were saying before the importance of using this information to facilitate the dialogue between physician and patient in clinical practice, but also this is going to be helpful for discuss the importance of the treatment, of the innovation at the regulatory level, because if we don't discuss in that scenario the importance of innovation, we are also going to get some barriers in the access of those treatments. So DIVA is going to facilitate this context thanks to the patient testimonies, and we are ready for that.
Thank you. And since we don't have that much time, if you have any burning questions, just raise your hands. I pass you the microphone, because it's supposed to be also an interactive moment. There is another interesting aspect that was touched in the presentations, and I think it's another burning issue, at least as we saw in some areas of the world, is the type of administration. Many of us, even when we were discussing and we were looking together at the results, we have been not surprised, but we were thinking about the fact that the mode of administration is seen as a priority in different ways depending on the regions and depending on... So I think it's important, because we thought it was one burning issue, at least among our restricted community, but what you can add and what you can say about that?
It makes sense. First, what a patient wants is to be okay. If a route of administration makes a difference in other dimensions, of course. But first, we need to be okay and feel the value of the proposal to get to help us to get better. if a new drug or a current drug is not offering you that improvement, it doesn't matter the way of administration. But it makes sense. First, efficacy. Then we can discuss safety and also the route of administration and the burden of getting that treatment. But it makes sense.
So, before giving you the floor, what is, sounding in my mind is again quality of life that needs to be strictly combined with quality of care. So in this context, the way of administration can be complementary to the improvement of quality of life, while it's not just the answer. You can have the best possible way of route of administration, but it doesn't change your quality of life or the effectiveness of your treatment. I think it's an interesting point. Vaso, you wanted to comment on?
A very short comment that, of course, patients are more concerned for the effectiveness of their treatment instead of the route of administration. And let's keep in mind that when we face a chronic disease like IBD, the primary focus is to relieve from the symptoms and to have a long-term stability and quality of life. So that makes sense, and it's completely normal to see that people prioritize effectiveness over route of administration.
Thank you. I was looking at the audience and several heads nodding. Do you have any reaction about that? Or you want to say something more or something different?
Hi, my name is Steinar. I'm from Norwegian Patient Organization, also writing as a freelance journalist for the Patient Organizations magazine. And I've been writing a couple of articles about administration, among others subcutaneous medication. I have to say, as a patient myself, I see in Norway how effectiveness, how the hospital management goals to save money also is a part of this. And I'm actually a bit skeptical to if I have no problems with understanding that it's very easy to take like JAK inhibitors as tablets or this subcutaneous syringes at home every second week, and it has some advantages. But my question is, what do you think that will do combined with the hospital management and authorities' goals to save money? What will it do with how the patients are being followed up? Because, for example, I go to hospital every 6 weeks and get an infusion. My doctor wants me to come there every 6 weeks instead of just stay at home, because then he has better control. We had the blood samples, and what do you think will happen with how the patients are being followed up if when the administration is getting more and more home-based?
I can just give you a quick reaction and then I pass the floor to Roberto and Vaso. I think that the first element we have to take into consideration is that despite we are in the European Union and we are representing the world, there are a lot of cultural and organizational differences in countries. So national health systems are working in different ways. So even the choice of administration often depends on what is available in your country or not. So this is the first general thought, and then to go more in depth and listening to the patient's perspective, I will pass the mic.
I love the question because the study is about the patient preferences. However, I was speaking at the regulatory level, the decision-making process, also the discussion we need to have with the STA bodies to introduce the new drugs in the market. And they are asking us not only about our preferences to estimate the value of the new products, but also the consequences or introducing those drugs. And the consequences, maybe our preference is to use one option. However, the consequences of using that specific option is going to improve the way we are monitoring the patient, or even the consequences can be negative. And we need to consider that, because some patients are not adherent to products, to their treatment. So how we are going to impact the health outcomes we are getting in current clinical practice, also introducing the patient preferences in the decision-making process. So this is a very relevant question, and we need to get the answers, because this is a new way to approach the way we are practicing.
Okay, I completely align with Elise and Roberto, so I will not repeat the same, but also I will add that maybe we will find difference between age groups, because younger patients, as we discussed with the youth group, tend to prefer treatments that are outside the hospital settings, because they want to travel, they want to study, they want to work, they want to have a social life, and they don't want to be in a hospital. So we will find difference in different cultures, in different countries, and in different age groups.
So I give you the hook. I think, Roberto, you already mentioned it. There is also the big issue of health technology assessment, because I see that currently, even in the debate at the policy level and also decision makers levels, very often we are only focused on the cost effectiveness, so on the financial side. And in that case, if I well understood what our friend from Norway was saying, very often even the treating physician, the follow-up, whatever we want to call it, are suggesting a certain form or a certain route because they are less expensive. But we know, generally speaking, not necessarily what is less expensive is the real preference of a patient. And I think we have a certain margin of discussion when it comes to advocacy, if you are able to show that cost effectiveness can't be the only answer to the choices that the government or a payer is doing. Can you comment on it? $1 million question.
Cost is one of the most important aspects of before deciding to introduce a drug, and how we are flexible or not to use it, even when it's available in our countries. And that's, of course, we know that. However, what is new is how we are going to introduce new dimension in the discussion. We are starting the debate because even we don't even have the algorithm, the aspect, how to introduce these preferences in the algorithms. Now they are using an Excel to compute the benefits of the new drugs, comparing with other in the current market. However, they are using these formulas with clinical parameters because they don't know how to use this information. Of course, I'm going to discuss what is the weight of the patient preferences according to other important issues like mucosal healing. It is better to get the I don't know, any of them instead of the mucosal healing. How we need to estimate the value and what is the weight of the patient perspective in that discussion. This is exactly the discussion with the SGB bodies. They need to introduce this information with a specific weight. We need the methodology. We are starting to the dialogue with them, but we don't even have the methodology.
Yeah, one sentence only for me. One only sentence. Behind every number is people. Real people with real lives and needs.
Bente, you want to comment, say something?
You are talking about life quality, but it's just a new thing in Denmark, at least. When you look at medication and stuff, we are talking quality. And that's made out of when you have studied the population and see what is good, what is the pain and stuff like that, and how much quality do you want for these medication. So it's coming in from outside to look in, because they have realized over the last decade that life quality for patients is actually very important. So I have a question for the survey. Have you thought about, when you made the survey, that often when we get these questions, we often answer for what we feel right now?
I think, well, Roberto first, but I think Elise in a way already explained a bit before, I think after another question. You want to comment on, Elise, please?
Yeah, I think it's a very good question that you raised, because of course personal circumstances can really influence the preferences that patients have at that moment, and that's why we asked like all the different background questions, really to put our results into the perspective of who answered the questions, which disease status did they have at that moment, which treatments did they have experience with, were they taking at that moment. But that's indeed something that, yeah, the preferences of patients of course are influenced by the disease status of the patients, like if they're in remission or not, but that's something that we took into account, and where we also did some sub-analysis on to see if there were differences in the preference of the patients, if they were in remission or were not in remission, or did not start their treatment yet, or were just diagnosed and so on. So that's how we took that aspect into account into our study.
There is Anastasia. Don't kill us, Maria Stella. It's the debate. There is Maria Stella. You need to finish your session, but I think it's important. I mean, it's our moment, let's say.
It's more like a comment. In their very honorable and hard effort to put us in remission, sometimes our doctors may not really evaluate the patient's concern about some very rare side effects or some very rare conditions that may happen, and they just brush off saying, oh, this is only 0.7%. But for the patient who actually has this side effect in the end, it's 100%, it's not 0.7. And I think that's what reflects in this survey. There is a 7.9 concern about 7 point whatever, sorry I cannot see that far, for risk of surgery, while only 30% of patients, including me, in the survey had the surgery. So this is a 3%, 30% chance, which is not that big of a deal, but for every person who has a surgery and every routine, easy, I'm having 100,000 of them till today, surgery, the surgeon says, don't worry, it's a routine procedure. There is a significant chance of dying. And I think that's what we have to focus on, that behind every tiny minor percentage, there is someone who has 100% of this, because it happened to him or her.
Thanks, Anastasia. I think that if there is any other super burning question, I will close the session and then I will pass the mic to Maria Stella. Just to conclude, I think that, as I was mentioning, this is just a starting point. What we would like to know is not only collecting your reaction, like yours, Bente and Anastasia, the last ones, but really working with the national members to identify which can be the take-home messages also at national level. Because we know that depending on the countries, on the national health systems, on the payers, on everything, we have a lot of variables that are not only for Europe but for the rest of the world. We need really to fix some elements that can help you. So we need to tune the national data in a way that can be really a good instrument for you to better understand your needs, if the case, but also to talk to those that at the end of the day will take the final decisions on our health, our treatments, and and our routine. That should not be living with fear because you don't know what's going to happen next. So thank you so much. I give you the floor. I give the microphone back to Maria Stella.
Yes, I have it. So I want to invite to the floor Cathy Walsh from N-ECCO, who will give us the last presentation of today's meeting before wrap up the conversation. And yes. Okay.
Welcome, Cathy.
My name is Cathy Walsh. I'm an advanced nurse practitioner and a registered nurse prescriber. I'm from County Donegal in the Republic of Ireland. On behalf of the N-ECCO Committee, thank you very much for inviting us here today. The N-ECCO Committee, there are 5 nurses. As I said, I'm from Ireland. We have a nurse from the UK, Belgium, Netherlands and Italy. This is the 19th meeting that we're having today. So my first talk refers to what N-ECCO is, so N-ECCO and what it offers. So yesterday we had the 16th N-ECCO school, and this is for nurses to have been working in inflammatory bowel disease, maybe an endoscopy or an infusion unit that want to learn more about inflammatory bowel disease. And it's a good educational start for them. We also have the network meeting which has been held today, and that is geared for more advanced nurses. Then we have the research forum, which is run every 2nd year, and that's to guide and advise and educate nurses about research and how to undertake it. Alongside that, we have the N-ECCO research grant. That is an €80,000 funded grant for a 1-year project through an application process. We have a similar one for a travel award as well, where a nurse who would like to work in an alternative centre and gain education and knowledge of a centre of interest, and that's the value of €1,500. We also have an N-ECCO school travel bursary for any nurse that would like to go to the N-ECCO school that requires funding. Our N-ECCO consensus statement was developed in 2013, redrafted in 2018, and we're planning to redraft that again as well next year. And this provides a standard of care about the various aspects of how we manage inflammatory bowel disease as nurses. We also have our IBD curriculum and IBD nurse education programs. The IBD curriculum is via the ECCO portal, and we have 15 aspects of information and education for nurses from basic to advanced level. The IBD nurse education program is run every 2nd year through the ECCO support, and that's through application through a country that may want more updates to also get more nurses who may be working in another area that would want to get more information about inflammatory bowel disease for their career pathway. And we have the ECCO online learning platform as well. So I was asked to just sort of highlight about IBD nurse training, and just from talking to some of my colleagues, we have lots of different ways of how nurses gain information and education for IBD nurse training. Unfortunately, some countries have quite limited education, and other countries are a lot more advanced. So we're doing a huge amount of work over the 19 years since ECCO have been developed. And some of the updates then for 2025-2026. As I mentioned, we want to update the NECCO consensus, and this will be the third version of this. As we know, the ECCO and IBD, there's evolving and developing as the years go by, and we feel we want to update this as it's 5 years overdue. The Train the Trainer programme is commencing in 2026, and this has been in development in the last year, and the purpose of that is to accelerate and widen the access to provide a high quality of IBD nurse training, and this is going to enable nurses to provide high quality of care to patients. And it's nurses, their first language is not always English, and it's quite difficult when they come to the NECCO school and the network meeting to try and take in all the information. And this would be a 2-day training program led by the ECCO faculty. And it's implementing the e-learning IBD nurse curriculum, and it's going to be a concise course that's run independently in the country of chosen application in their institute. So other opportunities that IBD nurses have for training at local level in their own hospital or local university through study days. We also have pharmaceutical input and study sessions run as well. At a national level, we have conferences such as in Ireland. We have the Irish Society of Gastroenterology. We have our own IBD Nurse National Committee study days which we run, and we also have input from pharmaceutical study days and conferences. And on the European side we have our Nurse ECCO, as we have here at the moment. One of the questions just I was asked to highlight was just to talk about patient preferences as regards medication. And from a nurse aspect, the various, as we all know, the different types. We have oral medications in the form of mesalazine, steroids and biologics. We also have topical treatment in the form of suppositories and enemas. And we have intravenous and we have subcutaneous treatments. But also then it's just which treatment and what the patient preferences would be. From my personal experience of working with patients for the last nearly 20 years, initial responses would be yes to tablets and infusions and no to suppositories, enemas and injections. I suppose tablets, when we started a long time ago in inflammatory bowel disease, tablets was the first form of medication that we had, mesalazine and steroids, but they've progressed now to the small molecule treatments and they have a bigger side effect profile. I suppose patients like to have infusions, they feel security coming into the hospital, that they're going to be monitored and followed up closely, and they have good contact with the infusion nurses. The initial response, I suppose, for suppositories and enemas, it's probably the invasive procedure of having to take these treatments every night, and also then with injections. Some people have a fear of needles, even though we now have pens where you don't see the needle, but it's a self-injection seems a bit daunting for some people. My experience really is that we should have good knowledge of the disease explained to our patients, because as we know, the location of the disease, the type of disease, whether it's Crohn's or ulcerative colitis, and the actual site of the disease decides which treatment options. As mentioned earlier, shared decision making has been highlighted today, and it's very important that the patient makes an informed decision. So for example, if somebody has proctitis, a suppository will be a more effective treatment. It's really important that we offer treatment options and choices where possible, and really important that we give adequate information from a reliable source. Unfortunately, people talk to other people, they talk to their neighbours and have hearsay information, but it's really important to get adequate and accurate information from a healthcare professional, such as your consultant or your IBD nurse. We go through the side effects, but we also talk about the risks and the benefits, And duration is another big factor as well, how long somebody's going to be on treatment. It's not something that's weeks or months, it's generally for years because of the chronic nature of the disease. Patient support groups are really important, and I would be quite proactive in organising patient support groups. I think it's really important that people learn from each other, and adherence is a key when we're talking about medication, and it's really important to explain to somebody who's well why to stay on treatment. Thank you very much.
It's open.
We just heard what the need of the patient was, and as I see what you had up there is helping the doctor to provide the medication and help the patients. But I hear in this new study that the patient wants to talk about and have help with fatigue, what is going on for them in the daily life, their life quality, because they know for sure they will get the medication, but it's all the other things. How do you think you can work that in the program? Because I can't see the patient in the program for the need we see in this investigation here.
Oh yeah, well, as a nurse, so we have a lot of factors to cover when we're talking about it. I was just covering medication today because of the time frame. But as an IBD nurse, when we're talking to patients, we have a lot of factors to cover, and also our time as well. But fatigue, as well as diet and medication, is always included in our care of patients. Is that what I've answered for you? No?
No, because we know in Denmark, we made some studies in Denmark, and it was a study made by the doctors, by the nurses, and they figured out that they are actually, the nurses thought they were meeting the patients, but it came out that the patients wanted to talk about sexuality and things like that, which the nurses admit that they were not very good at. And I can see, when I see this running through, then I think, but there are certain things that is not.
And that's a very good point, because actually, interestingly, sexual well-being and sexual health is one of our presentations at our network meeting today, to highlight that, as something, how we're going to discuss that with patients. It's something that's, being highlighted. So we've got some very interesting research that's being presented today at our network meeting. So.
As we are running late, I will welcome one more question, then we have to close. There's another session after us, so we are quite late.
Sorry, I have two questions, but maybe we can make it quick. So the first question is if you considered, or if there are, like, for example, disability justice trainings for nurses, or even discrimination against this, because I have some friends, and even myself, we go to our doctors, and then we experience some discrimination concerning disability, that's like just some comments, or even a person is not really feeling well in their doctor's place, because maybe they even experience racism or stuff like that. So that's one question. Concerning, for example, stress, like just since there are certain languages or comments that's and the other question is how you evaluate the relationship between nurses and doctors, and if it is possible, or if it would be better to give more power to the nurses in comparison to the doctors, and how this also is different in different countries, right? For example, in Germany, And I feel it especially also in my clinic. There's a huge divide between nurses and doctors. And although nurses can actually do almost everything the doctors can, and they might even have like almost the same knowledge, kind of. And yeah, I also feel it's not making the atmosphere in the whole practice so good, because there's this huge division. And I feel that's the other question I have for you, if you have some thoughts on that.
It's hard for me to, I don't feel a division in the service where I work. Obviously there's lots of different things going on. As patients, you're under the care of a consultant, and we work as a team. So you may see your physician or consultant for a short period of time, and there's, a patient once said to me, you've got so much time to talk with me, and I said, well, that's my job, to have the time to talk with you. I find, that patients can talk more freely with the nurse with, issues like maybe sexual well-being, sexual health, fatigue, relationship issues and things like that. They tend to get upset, maybe emotional, that they would never do with the doctor, but my expert knowledge, I know how to, over nearly 20 years of working as an IBD nurse, sort of how to ask questions, and it's not just all about the clinical side of things, it's looking at the bigger picture, as we talked about here, fatigue, and our assessment is maybe a bit more in depth at the holistic picture, so I don't know if that helps answer your question.
Yes, we are closing now, so I want to give thank you very much, Cathy, for your presentation, for your intervention. I want to give the floor to Salvo for the closing remarks, but before we wrap up, the purple team, please go to Vaso. Where is Vaso? Please go to Vaso and go with her to the meeting. Thanks for the cooperation. So, Salvo.
I hope you found this event and the survey as much interesting as I did, and for the number and the quality of the question, I must say yes, right? Everybody's happy with that. Well, while listening to the speakers, I was thinking about something. In 2012, we organized an event where we focus on early patient involvement in research and advocacy. In 2019, we organized another event and we moved from awareness to structured patient involvement in research and policy. So today, I think we took another step forward, and the question of Xavier was a clear evidence of that. I mean, 20 years ago, some items that we saw in this survey were never considered. So this means that we are in the right way to make this world a better place for patients and their families, for IBD people, the people we represent. Well, of course 2 hours are not enough. This is just a starting point. And the progress is a manuscript that is under development. Of course, the result will be shared on a EFCCA talk after the manuscript is presented. And then after that, of course, we will share the national data with our members. That probably will be one of the most important findings, country by country, in order to give us more evidence. This is the importance of involve our community when we present surveys. I mean, you see, it's a clear result, and thank you again, Leuven, for the analysis of the data, because it's important. The first form of participation is to ask our people what they think about a particular items, a particular topic. So today we have the clear evidence that working in a good way like we did, it's important to change people's life. And thank you all. Additionally, today's presentation and the video will be shared on our website. Thank you again for your participation. Thank you to our members. Thank you to the staff. And thank you particularly to Maria Stella De Rocchis for coordinating this wonderful event. Thank you so much to the 1,500 people who answered our question, and thank you so much. Oh, sorry. The board and the staff. The board, Marco, Kira, Magda, who's not here, but she's a good reason to not be here, and the staff, and see you next time. Thank you so much.